G'day guys, it's Dr. James Simcock here, and just going to run through a short video on a fracture repair that I did during the week. And I was unable to film the fracture. I had to duck into a meeting straight after the surgery, so I was really pushed for time, so I wasn't able to actually film the fracture repair for you. But I thought it was an interesting one just to run through the kind of thought process and how we plan out these fractures and some of the software that we use to do that. So the first thing we're looking at here is the pre-operative X-rays. So it's really important to try and get nicely positioned and X-rays that are as straight as you can to try and assess the fracture segments. I guess before we get there, the sigament of this dog was a 6-month-old cavoodle, so 5-kilo dog, and relatively young. We can see some of the growth plates are still open there. So when we've got our X-rays, we want to make sure that we can assess those, and really the reason we're looking at these and considering the sigament is we want to give this fracture a fracture classification score, or I don't specifically give them a number, but just to kind of go through the thought process and thinking about what kind of fracture is this, what kind of considerations are there going to be when I look at repairing this fracture, what kind of implants am I going to use, and just what do I need to be thinking about in terms of stability and those kind of things. So I guess from a patient standpoint, this is a young dog, so it's going to have good healing capacity, good biology. This dog actually did have a small open wound here, so that this part of the femur had actually poked through the skin here, so it was technically an open fracture. And so one of the things we do want to consider is the amount of contamination of the fracture, and so this is technically an open fracture, or it's classed as a grade 1, so fairly minor. The other things we want to look at then are kind of the configuration of the fracture. So we can see that it's a complete fracture, it's quite displaced, and I would say that's a relatively low energy fracture. It's a fairly simple kind of short oblique to transverse fracture. It's just it's kind of 2-piece fracture here, and I think we can have a good option when we repair this to actually have some load sharing between the implants and the bone here. So to kind of review that, we've looked at the patient, his age, signalement. He's a young active dog, so you're going to have to keep him quiet, consider the patient factors there, owner factors there. Location of the fracture, we want to assess which bone. So we've got the femur here we're dealing with. We're in the kind of distal part of the diaphysis or proximal metaphysis. So this bone in this region should heal relatively well. It is a young dog as well, so that's going to help the biology. Remembering that diaphyseal injuries generally don't have as good a biology or as good a blood supply as the metaphyseal injuries, and so generally going to take a little bit longer to heal. With the configuration, again, low energy fracture, so there's going to be potentially less damage to the soft tissue envelope, although there is some displacement here in this. This piece of bone was poking through the skin there, and again, it was what we call a type 1 open fracture. So with those fractures, there's going to be a little bit of contamination that we need to contend with, so we're going to flush this side out really well when we do the surgery, and then we're also going to put this animal on antibiotics. So they're the first things I'm thinking of. When I actually come to repair this fracture, there's obviously a whole bunch of ways we can do this. Typically for these kind of femoral fractures, I'm going to use a plate and screws and potentially an IM rod. In this dog, we can have some load sharing most likely here between the fracture and the implant. So I didn't think we needed to go with an IM pin as well as a plate, and I was happy just to go with a plate to repair this. But you could have fixed this with an external fixator, potentially an interlocking nail. You could fix it with orthogonal plates, but again, those things are probably not absolutely necessary in this particular case. So the next thing I wanted to show you, if we move over here, is some of the planning software that we use, and I've talked to you guys about this program before, which is called VPOP Pro. And so what it allows us to do is to actually put these calibration markers on, and we can actually calibrate the image, so we can actually then select different implant sizes, and we can bring that over and work out what we need to use. So in this particular case, I'm going with a fixin plate. I really like these plates, and I can select through the different sizes here. So I'm just looking past my camera to see what we need to use. Different sizes. There's a whole bunch of different implants that are available in this system. When I'm actually looking at this fracture and deciding where my implants are going to go, I'm also trying to assess if there's any fissures in here that I'd need to be aware of. I'm going to aim to get 3 screws below the fracture and 3 screws above the fracture. In this particular case, I'm not going to span the whole length of the bone. I actually want this plate to have a relatively short working length, so that's the distance between these 2 holes here. Because this is a relatively simple transverse fracture, I want it to have a relatively stiff construct. So if I put a longer plate with a longer working length on here, that would actually have more ability for some bending and micromotion, and that would not be as stiff. And so that might actually be a little bit detrimental in this particular situation here, where I want quite a stiff construct. Okay. So that's the kind of plan we had when we were setting this up, some of the kind of things I think about when we do these repairs. When we look here at the post-operative X-rays, let's try and rotate that around so you can see it a bit better. And we'll zoom that up. Oops. So you can see, come back here. So we can see this is our post-operative image here. I'll just switch over to here and pull up the post-operative AP view as well, which is this guy here. And so when we're looking at the post-operative images, we want to assess the 4 A's of fracture healing or fracture repair, and that's looking at the apparatus, the alignment, the apposition, and then potentially the activity end. So remember that this was a dog that is just immediately post-op, so there's not going to be a lot of activity that we need to worry about. So I'm just going to change the windowing on these a little bit so I can see it a bit better. So on the lateral view, we can see our alignment is quite good. What we're looking for here is looking up at the greater trochanter, we can see the femoral head sitting just in front of that, so we haven't created any torsional issues. We can see that we've got a nice straight view of the femoral condyles there, so alignment on the lateral view looks good. When we look at alignment on the AP view, I think that looks pretty good as well. We've got a mild amount of distal femoral varus in here, but I think it's appropriate for the dog, and I think probably within the normal range for this, this particular patient. The apposition looks pretty good. We've managed to get the fracture ends aligned quite nicely. I have effectively over-reduced this leg a little bit on the lateral view here, so the femur typically has an amount of procavatum, and with over-reduction I've just straightened the leg out a little bit, and that helps me to get better screw placement here and helps potentially to have the patella tract a little bit better as well. So not a big issue. It's not absolutely perfect there, and that'll be completely fine. The apparatus then, when we look at that, we can see that I've got 3 good bicortical screws in the proximal segment, and I've got 2 bicortical screws and 1 monocortical screw. And the reason for the monocortical screw is that I wasn't sure in surgery how close I was going to be to this intercondylar notch. And you can see here that this screw probably would have just passed above the intercondylar notch, but I wanted to try and avoid that, or avoid penetrating that and crossing it with the screw. So having 2 good bicortical screws, these are locking screws, and then having this monocortical screw is going to be plenty for that construct. Nice stiff implant, and I think this will heal quite nicely. It's short up on the transcortex there, so we'll have some load sharing. So I think that looks pretty good. I'm pretty happy with that. Patella is tracking well post-surgery. We want to make sure that we don't have a patella luxation that we've induced. So overall, pretty happy. So hopefully you enjoyed that little video, a bit of an overview as to things I think about when I'm repairing a fracture. Remember, if you have any questions or comments, just feel free to reach out to us, and if you have any ideas on videos you'd like to see or tutorials you'd like to go through, just certainly feel free to reach out. Hope you guys are having a great day, and we'll see you all soon.